Gastroesophageal reflux disease, or GERD, is a common concern for patients who have undergone bariatric surgery. In this video, we'll explore why GERD can develop or worsen after weight loss procedures, especially sleeve gastrectomy, and what current research and expert consensus recommend for managing these symptoms. We'll also discuss the differences between various bariatric surgeries and how they impact GERD risk. By the end, you'll have a clearer understanding of the causes, evaluation, and best management strategies for GERD after bariatric surgery. GERD, or gastroesophageal reflux disease, occurs when stomach acid flows back into the esophagus, causing symptoms like heartburn, regurgitation, and sometimes injury to the esophageal lining. This happens when the barrier between the stomach and esophagus, known as the esophago-gastric junction, fails to prevent acid from moving upward. Factors like increased stomach pressure and weakened sphincter muscles contribute to this condition. Understanding GERD's basic mechanisms is crucial for appreciating why it can be a challenge after bariatric surgery. Obesity is a well-known risk factor for GERD. Studies show that people with obesity are significantly more likely to experience GERD symptoms compared to those with a healthy weight. Increased abdominal pressure and changes in anatomy can make reflux more likely. Interestingly, weight loss, whether through lifestyle changes or surgery, often leads to improvement in GERD symptoms. However, the type of bariatric surgery performed can influence whether GERD improves or worsens. The two most common bariatric surgeries in the United States are sleeve gastrectomy, SG, and Roux-en-Y Gastric Bypass, RYGB. Both are effective for weight loss, but they have different effects on GERD. While RYGB often leads to improvement or remission of GERD, SG is more frequently associated with new or worsening reflux symptoms. Understanding these differences is key for both patients and surgeons when planning surgery. Sleeve gastrectomy involves removing a large portion of the stomach, leaving a narrow tube or sleeve. This new shape can increase pressure inside the stomach and make reflux more likely. Studies have shown that up to 50% of patients with pre-existing GERD may experience worsening symptoms after SG, and new cases of GERD can also develop. The way the sleeve is constructed, including its shape and how close it is to the esophagus, can influence GERD risk. Roux-en-Y Gastric Bypass is considered the gold standard for treating GERD in patients with obesity. This procedure creates a small stomach pouch and reroutes the intestines, which reduces acid production and speeds up gastric emptying. Most patients see improvement in GERD symptoms, and some even experience remission of Barrett's esophagus. However, rare cases of new GERD can occur, often due to technical issues like a large pouch or short roux limb. While sleeve gastrectomy and gastric bypass make up the majority of bariatric surgeries, other procedures, like biliopancreatic diversion, with duodenal switch, BPDDS, adjustable gastric band, AGB, and single anastomosis duodenal bypass, with sleeve gastrectomy, SUDIS, are also performed. These surgeries are less common, and research on their impact on GERD is limited. Some evidence suggests BPDDS may resolve GERD in patients who had it before surgery, but can also cause new cases. SUDIS may increase the risk of bile reflux, which is particularly concerning for Barrett's esophagus. Endoscopic sleeve gastroplasty, ESG, is a newer, less invasive weight loss procedure that preserves the natural anatomy of the stomach. Recent studies show that ESG can lead to significant weight loss without increasing the risk of GERD. This makes ESG an attractive option for some patients, especially those concerned about reflux. However, more research is needed to compare ESG directly with surgical options regarding long-term GERD outcomes. Before bariatric surgery, evaluating for GERD is important but controversial. Guidelines differ on whether all patients should undergo endoscopy or just those with symptoms. Some experts recommend endoscopy for everyone, as unexpected findings can change surgical plans. Others suggest focusing on patients with severe symptoms or objective evidence of GERD. Ultimately, the choice of surgery may be influenced by the presence and severity of GERD. If GERD develops or worsens after bariatric surgery, a thorough workup is needed. This starts with a detailed medical history, focusing on factors like weight regain, pregnancy, or chronic conditions that increase abdominal pressure. Imaging studies such as upper endoscopy and gastrointestinal series help identify anatomical causes like strictures or hernias. In uncertain cases, pH monitoring or motility studies may be used to clarify the diagnosis. International expert groups have developed consensus guidelines for managing GERD after sleeve gastrectomy. They recommend that all patients with GERD symptoms considering revisional surgery undergo endoscopy and imaging. However, there's still debate about the necessity of pH monitoring and manometry in every case. These guidelines help standardize care, but also highlight areas where more research is needed. The first steps in managing GERD after bariatric surgery are lifestyle modifications and proton pump inhibitor (PPI) therapy. Patients are advised to avoid trigger foods, eat smaller meals, and elevate the head of the bed. PPIs help reduce stomach acid and relieve symptoms for many patients. If these measures are not effective, further interventions depend on the type of surgery and underlying causes. For patients with GERD after sleeve gastrectomy, management depends on weight loss success. If weight loss is adequate but GERD persists, conversion to gastric bypass is often recommended. Medical therapy can also be effective. Other surgical options, like banded bypass or hiatal hernia repair alone, are generally not supported by current evidence. The only controversial option is magnetic sphincter augmentation, which is still under investigation. If a patient has GERD after SG and also experiences inadequate weight loss or weight regain, conversion to gastric bypass is again the preferred surgical option. There's less agreement about whether medication alone is sufficient or if hernia repair should be added to the conversion. Each case should be evaluated individually, considering the patient's symptoms, anatomy, and preferences. Magnetic sphincter augmentation, MSA, is a newer device-based therapy for GERD. It involves placing a flexible ring of magnets around the lower esophageal sphincter to prevent reflux. Some studies show promising results for patients with altered anatomy after sleeve gastrectomy, but long-term safety and effectiveness are still being studied. MSA is not yet widely recommended for post-bariatric GERD, but it may become an option in the future. Other innovative therapies for GERD after bariatric surgery are being explored. The Stretta procedure uses radiofrequency energy to strengthen the lower esophageal sphincter, but results in bariatric patients have been mixed. Electrical stimulation of the sphincter is another option, with some success in reducing symptoms and acid exposure. However, more research is needed before these therapies become standard practice. Despite advances in understanding and managing GERD after bariatric surgery, several controversies remain. There is ongoing debate about the best preoperative evaluation, the role of advanced diagnostic tests, and which surgical or device-based therapies are most effective. International consensus statements help guide practice, but highlight the need for more high-quality research to answer these questions. Experts have proposed algorithms that combine the best available evidence for evaluating and managing GERD after sleeve gastrectomy. These algorithms typically start with lifestyle changes and medication, followed by imaging and endoscopy to identify anatomical issues. If GERD persists, conversion to gastric bypass is often recommended, with other options considered on a case-by-case basis. This structured approach helps ensure patients receive the most appropriate care. For patients considering or having undergone bariatric surgery, understanding the risk of GERD is essential. Sleeve gastrectomy carries a higher risk of new or worsening GERD, while gastric bypass is generally protective. Pre-surgery evaluation and careful surgical technique can help minimize risk. If GERD develops, a stepwise approach to management ensures the best outcomes. As research continues, new therapies and better understanding of GERD after bariatric surgery are expected. Ongoing studies will clarify the role of innovative devices, endoscopic procedures, and personalized approaches. Patients and providers should stay informed about evolving guidelines and emerging evidence to make the best decisions for long-term health. GERD after bariatric surgery is a complex issue with many contributing factors. Sleeve gastrectomy is most commonly associated with post-surgical GERD, while gastric bypass is often protective. Careful evaluation, consensus-based management, and awareness of new therapies are essential for optimal patient outcomes. As research advances, recommendations will continue to evolve, offering hope for even better care in the future.